Hello, everyone. Thank you very much for taking the time to check out my quality improvement project. First of all, I just wanted to thank all the faculty and staff at AT Still University when I decided to pursue this DAP program. I just wanted to do it to be a better athletic trainer. That was the only goal. And through your help, I think I definitely achieved that. Your dedication and passion for athletic training, education, and the advancement of our profession shows in everything you did as a faculty and staff, and I really appreciate it. And I want to give an extra shout out to Dr. Barton Anderson, who was instrumental in helping me complete this quality improvement project with his positive feedback and positive reinforcement the whole time. So thank you very much, Dr. Anderson. The problem that is looking to be addressed here in this quality improvement project is the lack of movement screening on the PIAA forms that the athletes have to have filled out before each sports season begins. Um, PIAA form can be filled out by a myriad of people: the primary care physician, a nurse practitioner. You can even go into a local pharmacy and get it done, like a CVS or a Walgreens. As you can see over here on the right, there is a section for musculoskeletal findings, but it doesn't do an actual movement screen. What they'll do is if the patient has a knee sprain, they'll check it off as abnormal and write in that they have to see an orthopedic and be cleared by the orthopedic before they may play. Uh, so as a result, there's really no way to identify any possible injury risks to the athlete, and that's what this quality of movement project is going to try to solve. Lloyd et al. And Valovich McLeod et al. Can show us the importance of these movement screens. Movement screens can be used to identify faulty movement patterns. The goal of correcting these altered movement patterns, as stated by Lloyd, is to improve movement proficiency for safe and effective long-term physical performance. Valovich McLeod, in agreement with the American Academy of Pediatrics, they state in the NATA position statement on pre-participation physical exams, the movement screen is to screen for athletes for medical or musculoskeletal conditions that may predispose them to injury or illness. This quality improvement project, we utilized the Plan, Do, Study, Act strategy. We actually had two PDSAs for this quality improvement project. PDSA 1, the plan consisted of a literature review to identify tests that were in the literature that we could use for a movement screen. The do part was actually the testing of our athletes, which I recorded with my iPhone. The study part was I evaluated the movement screens. And then the act part was I developed a rehab program for the athletes. PDSA 2, the plan consisted of meeting with each athlete individually to discuss their results. The do part was the athletes performed 12 training sessions of their rehabilitation. The study is we retested them doing the exact same movements. And then the act part was we will determine if the results showed if this movement screen should move forward and or what changes should be made. We'll get into more detail with each of these in the coming slides. A review of the literature showed that previous injury is the most common risk factor for future injury in football and soccer. Another major risk factor would be improper rehabilitation. Bell et al., they showed the effects of medial knee displacement, and they actually linked medial knee displacement with excessive pronation. They did this through two different mechanisms. First, their patients generally showed weak or tight plantar flexors, and secondly, they would show a decrease in dorsiflexion range of motion. A systematic review by Lima et al. Also linked medial knee displacement and decreased ankle dorsiflexion. Bell and Lima articles were pretty important in figuring out the test that we actually wanted to implement for this quality improvement project and really narrowed our focus, which I will talk about in future slides. So based on the literature review for this quality improvement project, we picked 3 tests, and one also has a modification to it. So you can say either 3 or 4 tests. The first test you see on the left there is the lateral step down test. The test in the middle is the overhead squat. Underneath it you see a 2x4. The modification of the overhead squat is you put a 2x4 underneath the heels. And then finally, we did the star excursion balance test. Some people call this the Y test because we did it in 3 different directions: the anterior, the posterior medial, and the posterior lateral. I will explain each of these and why we chose these tests in the upcoming slides. I chose the lateral step down test as one of my 3 tests because I think it's really important that my athletes can show good balance and be able to keep their knee in the sagittal plane without going too much into excessive valgus or medial knee displacement. This medial knee displacement has been shown to cause a bunch of injuries. It's been linked to non-contact ACL injuries in female soccer players. It's been linked to a lot of patellofemoral pain syndromes. And what we need to do is we need to be able to differentiate where this abnormality is coming from that's causing the medial knee displacement. Rabin does a good job of saying it either comes from the hip, the knee, or the ankle. Well, how do we differentiate where this medial knee displacement is coming from? Is it because something's wrong at the ankle, or is it because something's wrong at the hip? So that's kind of where we connect the lateral step down test to the next test that we're going to talk about on the next slide, is the overhead squat and the modified overhead squat. The test we did was the overhead squat and the modified overhead squat. Bell et al., they studied the characteristics of muscle strength and flexibility in individuals who presented with medial knee displacement. What they found was that the causes of medial knee displacement were generally found at either the hip or the lower leg. In order to differentiate between the hip or the lower leg, they introduced the modified overhead squat, which is reproducing the overhead squat, but this time they put a 2x4 underneath the heels of the patient. And when they did the squat, if the medial knee displacement, or it could have even been something like excessive pronation, if that disappeared, then it was thought that the issue was up in the hip area and not the lower leg area. If the issue was still present even during the modified overhead squat, then it was considered that the issue was probably at the lower leg area. For our final test, we did the star excursion balance test. And what that is used for is to assess the athlete's dynamic stability. Seto and Muka, they used the star excursion balance test to see if improved core strength would improve dynamic stability. While the findings weren't significant, the group that did perform the core strengthening exercises, they did improve their scores compared to the control group. Hale also tested chronic ankle stability patients using the star excursion balance test. And they saw their scores, these patients saw their scores improve after the rehabilitation program, range of motion, strengthening, and neuromuscular control. And then finally, Gribble et al. Showed that high school and collegiate athletes who scored lower on the anterior reach portion of the star excursion balance test were more susceptible to lateral ankle sprains. The planning phase of PDSA was done. It was time to get to the do phase, and this is where the actual testing took place. We tested 15 football players and 10 soccer players in the athletic training room. These sports were chosen because of their high volume of injuries sustained during the fall sports season. This is definitely the busiest season of my year. Testing took place during a 2-week period. All tests were recorded on an iPhone, and then they were transferred to a computer for easier analyses. Regarding the lateral step-down test, here's an example of the scoring sheet we used. Participants used a step-down stool of 22.5 centimeters. They did 5 practice trials on each leg, and then to do their actual trial, it consisted of 6 trials, and with the first trial not being counted. And this is consistent with a lot of the literature that you do not count the first trial. Next, we did the overhead squat and the modified overhead squat, and they were both recorded in 4 views. There was an anterior view, a posterior view, and both side views. For the quality improvement project, I had the participants perform the modified overhead squat, even if the overhead squat was normal. Going forward, if the overhead squat's normal, you probably don't have to perform the modified overhead squat. Next was the star excursion balance test. We have that mapped out on the floor of the athletic training room. And the participants did 3 different directions: the anterior, the posterior medial, and the posterior lateral directions. Each participant, they had 5 practice trials, and then they performed the 3 trials, and their score was averaged out in centimeters. This was pretty tough to do. I had to get down, hands and knees and record each movement. Probably definitely worth investing in a wide balance testing kit moving forward, which is something I will do starting next year. Well, the testing was done, we can now move into the study portion of the PDSA cycle. Here are the initial scores for the lateral step-down test. Grading was as follows. 1 to 2 would be considered a grade of good, 3 to 4 is moderate, 5 or greater would be considered poor. It's very interesting to note that 17 of the 25 participants showed some form of medial knee displacement. That some form means there's 2 ways you can either score a 1 or a 2 on that with medial knee displacement. A 1 would be if the tibial tuberosity moves medial to the second toe. A 2 would be scored if the tibial tuberosity moved actually medially to the foot. That'd be scored as a 2. If you're paying close attention, you'll see that there's only 24 participants here. One of the videos just for some reason did not come out well. I have no idea why. So that is why there are 24 for those of you who are paying close attention. Here's some of the results from the overhead squat and the modified overhead squat. The first chart on top here shows the region of abnormal movement patterns that were seen during the overhead squat. Most of it was at the foot and the ankle, a decent amount at the knee, and a little bit in gray there was the low back. Usually had a low back arch or a low back would round. When breaking down the foot and ankle, most of the abnormalities were excessive pronation, and there were 2 where the heels elevated. For the knee, the majority of the knee displacement on the overhead squat was varus and not valgus. This certainly needs to be looked at closely. I really can't figure out why unless I did something wrong with the test. I can't see that I did, other than maybe some of the kids started to had their feet out rather than straight ahead. They were told to go straight ahead with the feet. This is something I'd really like to hear anybody's comments on, if they have any suggestions as why that might be. That might help me a lot moving forward. I have a couple ideas, but I'd rather not say them. I'd rather hear what other people have to say. And thank you in advance for any comments on that. With the results of the data collected, we are now ready to move on to the ACT portion of the PDSA cycle. And a workout was devised by the athletic trainer to combat some of the abnormalities seen. Over here on the right, this is the workout sheet that the student was provided with in order to record their workouts. If you look up at the very top, the first one is balance on the tri-stretch and body blade in all 3 planes for 30 seconds each. And if you can move left from right, you can see the parentheses 1, 2, 3, 4. That's sort of the progression for this exercise, 4 being the hardest of the progressions. And then the next set of exercises was the core workout, and we concentrated on breathing. We did a dead bug and Russian twists for 3 sets of 20 repetitions each. And just like above with the balancing, there are progressions, and you can see in parentheses from 5, 6, 7, and 8 for the dead bug, 8 being the hardest, 5 being the simplest. Then exercise 9 for the Russian twist was a large base of support without weight, and then it goes all the way up to exercise 12, which is a small base of support with weight. And then finally we get to the more individualized portion here, where the tight and weak muscles were worked on. If a muscle was tight, we might have foam rolled, stretched it. If muscles were weak, we would strengthen those muscles. We'll talk more about this sheet on the next slide. Along the PDSA2, the plan phase, this consists of meeting with the athletes and planning out their rehabilitation program. I already explained the first 2 groups of exercises, which are standard for everybody, and then exercises 13 and 14 are the individualized. If you look at the bottom, I didn't explain that yet. That is the actual recording of their workouts. Try to make it as simple form as I can. There's an example. So for workout number 1 in that example, it says athlete writes in the date, and then they write in, they completed exercise 1, 5, 9, 13, and 14. And those 1, 5, and 9s, they can move up to a 2, a 6, a 10 as you progress. And this way the athlete can just easily and quickly record their workouts up to the 12 workouts. And this should take about 4 weeks. A little longer than that, obviously. We had spring break in the middle of it, so nothing is perfect when you're actually in the clinic. But 6 of the 12 kids did complete the 12 workouts, and it went fairly smoothly. This slide just tells us about the do section of PDSA2. Kind of explained most of it on the slide before, but once the exercise program is explained, the athletes would complete 12 times. And the first time, the athletic trainer, they would take the athlete through the program to make sure they understood what was expected of them. Specifically, exercises 13 and 14 were shown to them. And anytime the athlete had any questions, the athletic trainer was always there to demonstrate or answer any of their questions. And as if ideally, it'd be great to complete it in 4 weeks. But again, in the middle of doing this, we did have an Easter break or spring break, and didn't all get done within 4 weeks. But the 6 kids did complete all 12 exercises within a reasonable amount of time. If 6 athletes actually complete the workout program, and once they were completed, we can move on to the study phase of PDSA2. Here are the results from the lateral step-down test. Participants 1, 3, and 16, they actually did improve. They went from moderate scores to good scores. And athletes 17, or participants 17 and 22, they actually decreased. They went from good to moderate. And athlete number 23 stayed the same. So we did have 3 improvements. 2 did not improve and actually got a little bit worse, and 23 stayed the same. I wish everybody improved, but I still don't think this is bad. Some of it could even be my scoring, and that'll get better as time goes. But I was generally pleased with the lateral step down test. It is a difficult test for kids to do. Here are the results of the overhead squat from before and after rehabilitation. Participants 1, 17, and 22, they all had what I call a positive correction, where we resolved their symptoms. Number 16 was normal both before and after the rehab program. 3 and 23, they actually were both normal before the testing, but they did seem to have an issue after the testing. 3, you can see they had like a rounded low back, and number 23 sort of showed some right foot pronation that wasn't there before. Don't really know what to attribute this to, but something would definitely have to get looked into. And 22 did have a positive correction regarding their foot pronation, but I did sort of notice an excessive forward lean. Now, when I did go back and look at his, it might have been the same thing. I just didn't notice it the first time. So, not really sure how to, call that one, other than, it was probably there beforehand and I just didn't see it the first time. And finally, the results for the STAR Excursion Balance test. I was very excited to see these results because there was a lot of improvement in all 3 directions. And as we talked about earlier in the lecture, people who improve their core strength and do balance training improve their STAR Excursion Balance test scores, and improved test scores on the STAR Excursion Balance test can decrease your risk of ankle sprains and help with chronic ankle instability patients. So that sort of justifies the first 2 phases of the workout program I developed, using the body blade and the tri-stretch to balance, and then doing the core strengthening, the dead bug exercises, and the Russian twists. So the results here were very, very positive, while the lateral step down test and the overhead squat were very mixed. This was a very positive result I got out of this study. And finally, we have the lessons and limitations. The lessons I learned is I really need to get the Y balance testing kit because I think the data was fairly accurate with my measurements, but it's not going to be as accurate as if I have this testing kit. Um, and I also learned that there's probably no need to perform the modified overhead squat, which can move things along a little bit quicker if the overhead squat is normal. And as far as limitations go, equipment and space is a big limitation. I only had 6 kids complete all 12 of the workouts, but I did have a lot of other kids doing the workouts. They just never completed the 12 in the time I needed them to. So there was, some waiting around every once in a while. And that's not good because these kids, they're not really hurt to begin with. So sometimes they might have the attitude of, why am I here if I have to wait around? I can just go work out or do something else. And then finally, the biggest limitation is me. I have to get better at observing the lateral step down tests and the overhead squats and the modified overhead squats if needed. And once I am better at observing them and understanding them more, I can make up better rehab programs for them that are individualized. If you look on the rehabilitation for exercises 13 and 14 for the individualized ones.